In this matter of listening to heart sounds and murmurs, there are a number of tricks of the trade which may help you. Take, for example, the typical presystolic murmur of advanced mitral stenosis. As you listen to this, the rough crescendo effect immediately takes your interest. And when you try to distinguish this rough crescendo mid-diastolic from a rough systolic murmur, you invariably tend to concentrate on it and to disregard everything else you hear. This emphasizes the most important feature of training yourself to be a good auscultator, which is to listen for just one thing at a time. Now, if you artificially dissect this murmur from its associated heart sounds, it is easier to hear. And comparing it side by side with a rough systolic murmur, here's the difference. A presystolic murmur it rumbles up into the sharp mitral first sound. A rough systolic murmur at the apex this is always decrescendo. Fortunately for us, a presystolic murmur is always associated with and ends abruptly in a sharp mitral first sound. Now this sharp mitral first sound is not always a loud mitral first sound, but it always is short and high-pitched. Now here it is dissociated. And here is a reassembly of a typical presystolic murmur and a sharp mitral first sound. If a rough systolic murmur is heard in the aortic areas, that is, in the second right and the third left interspaces, and is accompanied by a second sound which is diminished or absent, or a second sound which is replaced by an early diastolic murmur of aortic insufficiency, it makes for a diagnosis of acquired aortic stenosis. But notice first that this is a rough systolic aortic murmur. In this case, replacing the first heart sound, and that there is no second sound heard. Sometimes the question is asked, if there are no heart sounds in the aortic areas, and only a rough murmur is heard, how does one know it is a systolic and not a diastolic murmur? Fortunately, because of the pathologic changes in aortic valve damage, there is always heard a sound or a murmur developed in systole if a diastolic murmur is audible. So often this aortic stenosis is accompanied by insufficiency of the valve that one hears good evidence of the combined lesions. That is, the rough systolic murmur followed by an early diastolic murmur. This early diastolic murmur either replaces or comes immediately on top of the second sound, and it is almost always blowing in character. But on rare occasions, it may be somewhat rough. With this particular illustration, there is also a short, rough systolic murmur, better heard when the rate is reduced to 40 per minute. This rough systolic murmur, however, in this case, did not represent stenosis of the valve because it was of syphilitic origin, with the commissures between the leaflets pulled apart, so that instead of narrowing, there is widening of the valve ring. This is a good demonstration of the fact that different etiologic types of aortic valve deformities cannot be distinguished by auscultation. And it is well to remember that occasionally this early diastolic murmur of aortic insufficiency may be heard when it lies at or outside the apex and not at the base. This is unusual, but it does occur, particularly with left ventricular failure. And of course, under such circumstances, this diastolic murmur, if heard at the apex, represents an aortic insufficiency and has nothing to do with mitral stenosis. Breath sounds are in the same frequency range as the early diastolic murmur of aortic insufficiency. Breath sounds and aortic insufficiency. So that if a murmur is heard at the base, it is important that the patient be examined with breath holding so that one is not misled. Many times with rheumatic aortic valve disease, there will be an associated mitral deformity with stenosis or insufficiency or both. In the matter of determining whether there is one valve or whether there are two valves involved may present considerable difficulty, because loud murmurs in one area may be transmitted to another area. It is a good working rule that if the character of a systolic murmur in one area is different from that in another area, one is dealing with involvement of both valves, because transmission does not change the character, that is, the blowing, rough, or musical quality of a murmur. So that if there is a loud, blowing, systolic murmur in the mitral area, and in the aortic area, there is heard a rough systolic murmur with typical evidence of aortic stenosis, one probably is dealing with mitral insufficiency and aortic stenosis. But if the systolic murmur in both areas is rough, one's only guide is the pitch of the murmur, which will remain the same if it originates in one valve, regardless of transmission to another area. Loudness of the murmur is not a guide, and it requires some skill to quickly move from one area to another to analyze and evaluate pitch. Under such circumstances, one is always helped by closing one's eyes, and this is another trick of the trade well worth cultivating. On occasion, combined aortic stenosis and insufficiency may be confused with a patent ductus. However, this murmur, when typical, extends through systole and diastole, in contrast to the murmurs of combined aortic stenosis and insufficiency, where there is a short interval between the systolic and diastolic murmurs. In general, auscultation is not nearly as valuable in making a specific diagnosis of congenital lesions as it is of other different types of heart disease, particularly those of rheumatic origin. Of course, alteration of heart sounds and disturbances of rhythm play a very important role in auscultation, and these may give a clue as to what is taking place, evidence of which may not be obtainable by any other method. For example, if a child with active rheumatic fever develops a diastolic gallop rhythm, one should be very careful to keep her at absolute bed rest until this disappears. If this same gallop rhythm is heard during the acute stage of myocardial infarction, one knows that cardiac reserve is diminished and that one is dealing with a serious situation. This gallop rhythm may not be loud. And it may be quite localized, most often at or near the apex. Usually it is a rhythm faster than 100 per minute, and there is no better description of it than a triple rhythm, that is, each cycle consisting of 3 sounds, with a lilt. This again emphasizes the necessity of listening hard for just one thing at a time, and training oneself to disregard everything else, such as the character of heart sounds and murmurs, if they are present. Sometimes an opening snap may be confused with a gallop rhythm. While each cycle of this opening snap consists of 3 sounds, even at a faster rate, it never develops the lilt of a gallop rhythm. Another finding, with each cycle having 3 sounds, is a systolic click of no known significance, usually heard along the lower left sternal border. A reduplicated first sound at the apex is not indicative of any specific abnormality.
Please click on Part 2, Heart Sounds.